Good evening, and welcome to your Facebook Live discussion, Real Talk with Doctors and Nurses. Tonight's topic is vaccines. I am Dr. Wayne Tuckson and have the pleasure of being your host and moderator for this session. This discussion is sponsored by and includes members from the Foundation for a Healthy Kentucky, the Greater Louisville Medical Society, the Greater Louisville Medical Society Foundation, the Kentucky Nurses Association, the Lexington Medical Society, and the Northern Kentucky Medical Society. The practice of vaccinations has probably been around since 200 BC, but the first recorded episode of a vaccination, which incidentally was for smallpox, was in China in the 10th century. It wasn't until the 18th century that the idea of vaccinations took hold in the Western world, and surprisingly, it too was for smallpox. The American Academy of Pediatrics News reported on a study that found that over the past 3 decades, childhood vaccinations prevented more than 500 million illnesses and 1.2 million deaths among children born here in the United States. Further, and equally important, this equated to over a $2.7 billion in savings in healthcare costs and savings to families and industries. We have choices, and there are many of us who, for many reasons, don't want to get vaccinated and really don't want to be forced to get vaccinated. Understandably, these decisions are informed by what is seen rather than not seen. We seldom fear the things that we have neither seen or experienced. The problem is, just because a threat is not visible or that we have not experienced it, doesn't mean that it has gone away. Tonight, we will hear first from our panel of experts, but as this is a discussion, at the conclusion of their short presentations, we invite and encourage you to post any questions, concerns, or thoughts that you may have regarding vaccines and/or vaccinations. Your comments and questions may be typed into the chat boxes, and we will try to answer as many as we can in the allotted time. If there are several similar or related questions, I will try to group them so that we may address the tenor of the questions. But please know that we will try to answer as many individual questions as possible. To get us started tonight, we'll first begin with Dr. Gary Marshall. Dr. Marshall is a professor of pediatrics and chief of the Division of Pediatric Infectious Diseases and is an attending physician at Norton Children's Hospital, where he sees patients in the infectious disease clinic. Dr. Marshall received his medical degree from Vanderbilt University, where he also completed his residency in pediatrics. He then went to the Children's Hospital of Philadelphia for fellowship training in infectious diseases. He is a recipient of the Plotkin Lecture in Vaccinology Award from the Pediatric Infectious Disease Society for, quote, contributions to the field of vaccinology or areas of related science that have impacted the lives of children and the specific area of pediatric infectious diseases, end quote. And he's also the author of the Vaccine Handbook, a practical guide for children. I give you Dr. Marshall. Gary, could you please give us a few comments?
Sure. And thank you for having me. And thank you for inviting me to speak about how vaccines are developed, because I think that's something that people don't know a lot about and don't really understand. The first step in creating a vaccine is understanding what causes the disease. You mentioned smallpox. It took centuries to figure out it was a virus that caused that disease. When COVID hit in 2019, it took days to understand what the pathogen was and what we needed to do to produce a vaccine. So we've made a lot of progress that way. Then we have to determine that vaccination is of public health importance and that it's feasible. And then we have to establish which components of the pathogen are the ones that stimulate an effective immune response. Those components are called antigens, and you'll hear that term many times probably tonight. Then we have to figure out how to isolate or express those antigens in a form that can be used in a vaccine and administered to humans and that will generate an immune response. So the first testing is done in animals. And I would point out that once the vaccine candidate reaches trials in humans, the entire process is overseen by the FDA. in an incredibly rigorous fashion. So the FDA approves every step along the development pathway. And there are several large tomes of guidance. One is called Good Clinical Practices, another is called Good Laboratory Practices, and then Good Manufacturing Practices. And these are the rule books that the FDA has established for, in the case of good clinical practices, how should we test the product in humans? What phases of testing should we go through? How should the research be done? And I've seen these GCPs, and I've actually had to implement them in our own clinical research. The public, I think, doesn't really understand the rigor under which these studies take place. For example, GCPs dictate everything from how the investigational product is shipped, what the temperature controls need to be, how a study should be blinded and randomized, what should be recorded in the chart of the patient. It even dictates how you should sign your name, and if you make a mistake, how you should correct the mistake. So this is all in an effort to make the research to have the utmost integrity in the results. I'll give you an example of a GCP. If a subject is on a clinical trial and receives the investigational vaccine, anything that happens to them is recorded as an adverse event. And that's without regard to whether or not anyone thinks the vaccine caused the event. So, for example, if a kid is in a study and gets a investigational vaccine and 3 days later falls off his bike and winds up in the emergency room, that is an adverse event that gets recorded in the database. It's only after the database is unblinded and the statisticians look at those data when they can determine that the fall from the bike happens just as often in kids who got the investigational vaccine as those who got the comparator or the placebo. So I'm just giving you an idea of what those GCPs are like. And the same is true for good laboratory practices. These dictate how the tests are done in the laboratory to determine if the vaccine produces an immune response. And the good manufacturing practices dictate things like what the criteria for stability are and for purity. There's even a rule about how much boron can leach off of the glass vial into the final product after a certain amount of time on the shelf. Another thing to point out is that all of the human studies take place under human subjects protections that have been in place for a long time. And that is processes like informed consent, which you're probably familiar with, that say if you're going to be in a clinical trial, here's what you can expect, and here are the possible adverse events and the possible benefits. So this development process goes through several phases. The first phase generally is in adult volunteers and usually less than 100 people. And we get basic information there about the safety and the tolerability of the product. Then in phase two, which usually involves hundreds of subjects, and usually those subjects are in the target group. So if it's a pediatric vaccine, it's children who are in the phase two study. And there we're looking at the safety first of the product, and then the immunogenicity, which means how well a person responds to the vaccine. And usually there, the vaccine is compared to a placebo or to a comparator if there's already a vaccine like that that exists. And then we go into phase three, which involves hundreds or thousands, or in the case of the COVID vaccines, that was tens of thousands of subjects. And there we're looking at immunogenicity and or efficacy. Efficacy meaning not only does the vaccine produce an immune response, but does it prevent the disease? And then after a vaccine is marketed, there's a phase four, which are the post-marketing commitments that are made by the company that produces the vaccine to continue to look for possible adverse events and to continue to assess for effectiveness. All of this takes place at the same time where safety events are monitored in real time. And there are a number of different processes for doing that. One is called the Vaccine Safety Data Link, where in real time, adverse events in people who have been vaccinated are fed into a computer system and analyzed on a continuous basis. So, for example, years ago, there was a rotavirus vaccine, which is a diarrhea causing vaccine in infants, that the vaccine safety data link picked up a little signal after that vaccine was being used commonly, where it seemed like a form of intestinal obstruction, intussusception, was occurring in kids who got that vaccine. And of course, that very rapidly was taken off the market. But there's other post-licensure safety processes like the vaccine adverse event reporting system and the FDA's PRISM system, and even pharmacovigilance programs, which are where the companies get real-time data on adverse events and are able to process that. And I wanted to wind up just by giving our audience an idea of the different kinds of vaccines that we have that are developed in this process. We have some vaccines that are based on toxins that are released from the bacterium. The best example of that is diphtheria, where we don't immunize kids against diphtheria, the bacteria. We immunize them against the toxin, the protein that that bacteria produces that can hurt children. We have other vaccines that are the whole virus, like the polio virus that's been chemically inactivated, or weakened live viruses like the measles virus vaccine. Some of the vaccines are just a single protein from the vaccine particle, like the HPV vaccine. We have bacteria that produce a sugar coating around them called a capsule, and some of the vaccines are produced from that capsule. And then finally, we have the mRNA vaccines, which are the newest addition that are honestly revolutionary in terms of how quickly they can be developed and how strongly immunogenic they are. And I know we can probably talk about that more later. So Wayne, that's my kind of that's the whole Purple Book in 8 minutes.
Well, thank you very much. I think we now will all run out and buy the Purple Book because that was a wonderful, wonderful discussion. I want to remind everyone that at the end of all the presentations, please, we will take your questions. So please filter them in, type them into the chat boxes so we can have them. Our next speaker is Dr. Michael Kudak. Dr. Kudak is an assistant professor of pediatrics at the University of Kentucky College of Medicine and is a pediatric hospitalist at Kentucky Children's Hospital. Dr. Kudak obtained his MD degree from the University of Medicine and Dentistry in Newark, New Jersey, and completed his residency in pediatrics at the Baylor College of Medicine in Houston, Texas. Among his many honors, Dr. Kudak is the past president of the Kentucky Medical Association. Dr. Kudak, Michael, please.
Thank you, Dr. Tuckson. I'd like to thank you for inviting me to talk on this Facebook Live, this important event. Hopefully a lot of people in the Commonwealth see this. And I just want to say it's really difficult to follow Dr. Marshall. He's someone who I followed his work over time. There was a pediatric conference years ago, which was in Louisville. He was a pretty consistent speaker at it, and he always had a lot of really good common sense things to say about vaccines. So I think a lot of what I've learned about vaccines has come from Dr. Marshall. So Dr. Tuckson asked me to talk a little bit about the current vaccination schedule and answer some questions about that and kind of what happens if people don't follow the vaccination schedule and the vaccination rate drops. So in my day job, I'm a pediatric hospitalist, so I see and treat sick children, and we're likely to start to see some of the diseases that we have vaccines against in the hospital sometime soon. Hopefully, if the vaccination rates stay low, we'll start seeing these diseases pretty frequently. So a lot of people have questions about the vaccine schedule, the number of vaccines given. People are concerned that it overwhelms an infant's immune system. And I'm going to answer some questions about that. First thing, I will definitely say that the vaccine schedule has grown over time. When I graduated residency, it was actually a fairly small number of vaccines that were out there, but we also saw a lot of these corresponding illnesses in pretty significant amounts, especially bacterial meningitis. I spent a very large portion of my intern year treating bacterial meningitis in ways, shapes, and forms. And folks like Dr. Marshall and other folks have been spent a lot of their careers trying to mitigate this disease and stop it. And we don't see this much anymore. So But there are a lot of shots, and I will definitely say that the people that make the vaccine schedule or make these suggestions have two things in mind. First thing is that we only include diseases which are serious. Serious means death, or in the case of like hepatitis B or human papillomavirus, prevent cancer. I'm going to repeat that because a lot of the stuff that I'm hearing in the media is talking on side effects and some erratum in some outlying data point in some appendix in some paper somewhere, and we've completely lost sight of the forest for the trees. So we need to talk about the diseases these things prevent because that's not in the conversation right now, and it needs to be. And that's actually vaccines are really effective because we don't see the diseases that they're supposed to treat. So number one, serious illnesses, cancer, serious illnesses now or in the future. Second thing I think we have to really understand about the vaccine schedule, babies get a lot of shots. Babies get shots at birth, 2 months, 4 months, 6 months, maybe plus or minus 9 months, depending on your schedule in a year. And the reason we do that is because a baby's immune system works differently than ours. So we have something called immunologic memory. So if you happen to get an illness that just has one serotype, let's say chickenpox is a good example. There's only one variety of chickenpox. Once you get that, you've had it. Shingles is a reactivation of old disease, but you can only get that once, right? Let's say like COVID is on the other end of the spectrum. You can get COVID at a limited amount of times because the serotypes consistently change, and there's hundreds out there. So, or the common cold, the rhinovirus, you can always get that over and over and over again. So, once you have something, you develop an antibody to it, and you're not going to get it again. So, uh, unfortunately, a newborn infant doesn't have that ability just yet. They are not really good at making antibodies. They rely on passive transfer of antibodies from mom. So antibodies come from the placenta, from the mom through the placenta into the baby, and that's the basis of their immune system. Everybody wonders why their babies start getting sick at about 6 months of age. And the reason is before that, they're protected by those maternal antibodies. They don't last forever. They break down over time. And when they break down, the baby's immune system is kind of just a blank notebook waiting to be written in. So and the reason we provide vaccines when we do is we don't want that notebook to be filled up with things like rotavirus, diarrhea, dehydration, bacterial meningitis, serious bacterial illnesses, whooping cough. These are things that kill babies. So people also ask, is there a lot of testing to determine the efficacy of these schedules? And Dr. Marshall kind of went into some granular detail about how the vaccines are tested. There's also some real life testing that happens. So he talked a lot about the pre-marketing thing that happens. Another thing is the vaccine schedules are being tested all the time because we're looking to see if these diseases we're supposed to be preventing are actually going away. So if they're not, or there's an instance where there's still some cases, we do something about the schedule. And this happened with the MMR vaccine. It used to be given at age 1 and age 12. That was the schedule back when I was in training. And we consistently had outbreaks here and there, even in fairly well immunized populations. So there was always something that was going on. So, and folks looked at this and said, hey, listen, if we move that booster dose to age 4, then those outbreaks should stop, and then they did. And we're starting to see outbreaks again, but the outbreaks we're seeing now are from low vaccination rates. So that's one thing. The other thing is Dr. Marshall kind of mentioned that there is a vaccine database called VAERS that people look at, and side effects or things that you would see from vaccines are there. But again, like I said, we have really lost sight of the forest for the trees because we're looking at some of these side effects, which are 1 in 1,000, 1 to 10,000, 1 in a million, and we're forgetting that, okay, people died of bacterial meningitis every day. Roll the clock back 50 years ago, people died of bacterial meningitis every day. Go back 100 years for antibiotics, people died of strep throat. So, and I think we really tend to forget that. So, I want to talk a little bit about herd immunity and what's going to happen if people stop getting vaccinated. And unfortunately, vaccine rates have been falling throughout the country for a variety of reasons. So, most folks are familiar with the concept of herd immunity. Basically, if you've got, let's say you have the measles virus is introduced into a population where most people have antibodies to it, right? So if people don't get the virus needs to infect somebody and get people sick. If it doesn't get people sick, it can't spread, right? So we had a case last fall or last spring. There was a measles case in Frankfurt, and that index case happened to run into a bunch of people that were immunized and that kind of died out. So that's how herd immunity works, right? So if less people are immunized and more people are susceptible to the whatever it is this pathogen is, and it starts to circulate, then it can take hold and start to circulate. That's what happened in West Texas. That's what's happened in other areas. And that's going to happen when the immunization rates drop to like 85% or below. So I work with the Kentucky Medical Association. I've worked with them on creating their vaccine policy and doing some other things. And I'm in Frankfurt pretty regularly to talk about vaccines. So for the past couple of years, there's been something called a conscientious objector law, which people have tried to introduce. I really don't know why people are objecting to this, because I think they're objecting to health. That's my personal opinion. But we are concerned that there may be some actions by the state government to make vaccination optional or not mandatory. This has happened in Florida, right? So my big concern is this: if you've got a group of people, people, they're going to have one of three opinions about vaccinations. They're either going to be pro-vaccine and they're going to get vaccinated no matter what. They're going to be anti-vaccine. They're not going to take the vaccine no matter what. There's going to be a group of middle that doesn't care, right? We're sitting here on a Thursday night, we're talking on Facebook Live, and there's a lot of other people watching baseball and football and could care less about this discussion, right? But it's really crucial that that group be immunized, because that's where herd immunity comes from. In our state, if you take all vaccinations and make them optional, your immunity level is going to drop maybe from 92, 93% down to the mid 80s. And that makes a big difference, because these diseases can take a foothold and then start to spread at that point. So I'll say one last thing before I hand this off to our next speaker. I'm a hospitalist, and I'm a little bit biased here, but I am really concerned that we're going to start to see bacterial meningitis come back. So, and a lot of the talk right now is about MMR vaccine. MMR does not cause autism. There are study after study after study that proves this. So it just doesn't. There's a lot of things we don't know what causes autism. It's complicated. Some of it's genetic, some of it's environment. There's many different things, but it's not vaccines. It's just not vaccines. So, but I am really concerned about bacterial meningitis coming back. So I think that's going to be the first thing that comes back when the vaccination rates drop. And I'm going to be really interested to see what happens in Florida. Look forward to talking to my pediatric hospital medicine colleagues next year at annual meeting and seeing what they're going through. But I really think that's going to be the first thing that comes back, because there's two major causes of meningitis in babies. One is something called Haemophilus influenza type B. If you're over 6 years of age, it doesn't affect you at all. I mean, you just carry it, and that's nothing. But if you're an infant, it can be lethal. And we who carry that bacteria are going to give it to children. So the other bacteria that's really common is something called pneumococcus. There's many different serotypes of that out there. There's probably 60-ish serotypes. Dr. Marshall probably knows the exact number. There's 20 or so in the vaccine, and the bad serotypes are in the vaccine. So when people stop taking the vaccine, those bad serotypes are going to come back. So we're going to have multiple resistant bacteria. People were concerned about the superbug about 15 or 20 years ago. Kids would come into the office and say, oh, please don't tell me my kid has a superbug in their ears. And they probably did, because it was multiple resistant pneumococcus. We got rid of that through vaccination. That's coming back if we stop vaccines. But I think my biggest concern is I think bacterial meningitis is going to be the first thing that comes back. And I saw a lot of that in my training, and I know how to treat it. And I was hopeful that I was able to take that piece of my learning and just kind of put it aside and never use it, but I fear that I may use it again. So, and I'll be happy to answer any questions at the end of our session. So thank you for inviting me, Dr. Tuckson.
No, thank you, Mike. That was outstanding, outstanding. And I want to remind everybody, you're going to hear, we will be hearing a lot of good discussion, a lot of good information during the course of this presentation. And this is being recorded, and it will be available for streaming to come back and take a look at it again down the road. So again, so don't worry if you miss something, you can always come back and pick it up later. Our next speaker is Dr. Mark Burns. Dr. Burns is an associate professor in the Department of Medicine at the University of Louisville School of Medicine and practices as an infectious disease specialist at the University of Louisville Hospital and at the VA. He earned his medical degree from the University of Louisville School of Medicine and then completed a residency in internal medicine and a fellowship in infectious disease, all at the University of Louisville Hospital. Dr. Burns, can you share a few thoughts with us, please?
Yes, certainly. And thank you for having me speak tonight, Dr. Tuckson. In preparation for this, I had informed a lot of people that this would be available, and I believe there are a lot tuning in. One question that seemed pretty consistent, especially with the younger people that I spoke with, they said, Dr. Burns, we understand vaccines have been around for a while, but why are they so important? And that really kind of struck me. And because, being an older individual, of course, I know the importance of it. And I thought, I think that would be a good time really to kind of talk about why vaccines are important. So if you don't mind, Dr. Tuckson, just thought I would kind of expound on this just a little bit. Vaccines are incredibly important for several reasons. They focus both on individual health and the community well-being. Vaccines, first of all, they protect individual health. Vaccines usually work by your body's natural defenses to build protection against infectious disease. They prepare your immune system to recognize and fight off viruses and bacteria, preventing you from getting sick or seriously ill. And even it helps prevent suffering complications that can lead to long hospital stays, permanent disability, or even death. The World Health Organization states that vaccines currently prevent millions of deaths each year from diseases like measles, tetanus, and influenza. Secondly, vaccines help to prevent spread of disease. Now, as a previous speaker was talking, when enough people in the community are vaccinated, it slows down or even stops completely the spread of disease. Now, this is known as herd immunity. This protection is especially important for vulnerable people who cannot be vaccinated, like newborns, or maybe the elderly, or those that are, it may also help protect those people who have weakened immune systems due to cancer or chronic illness. Another reason vaccines are important is they help reduce disease complications and long-term consequences. Now, vaccination not only prevents the disease itself, but also it prevents dangerous complications that it can cause. For instance, the HPV vaccine, as you previously heard, does prevent certain cancers. And the flu vaccine does reduce the chance of flu-related heart attacks and strokes. So this is another important reason. And finally, another important reason is it helps to eradicate and control diseases. Now, vaccines have been a major public health success, leading to the eradication of several diseases like smallpox and near elimination of others like polio and at one time measles. Because vaccine preventable diseases still exist in the world, some people remain unvaccinated and outbreaks can still occur. So in summary, vaccines are a crucial tool for public health. They help people of all ages live longer, healthier lives while protecting entire communities. I feel like it was important to explain the relevance and the importance of vaccines and why we have them. So, Dr. Tuckson, thank you again for the opportunity to speak. And I'm willing to take questions at the very end, as are the rest of the speakers.
Thank you very much, Dr. Burns. We appreciate your comments. Next, we'll have Ms. Denise Beach. Ms. Beach is the Public Health Director for Hopkins County, Kentucky. She earned both her Bachelor of Science in Nursing and Master of Science in Nursing from Murray State University. And in spite of her busy schedule, she is currently completing her doctorate in nurse practitioners and nurse practice at the Northern Kentucky University. She is the Public Health Director. She obtained the Public Health Director of the Year Award in 2021, and in 2024, the Kentucky Health Department Association Public Health Commissioners Award for Public Health Dedication. Equally important, in 2025, Ms. Beach was honored with the Lifetime Achievement Award by the Kentucky Health Department Association. Ms. Beach, can you give us a few comments, please?
Yes, thank you. I am going to talk a little bit about school health and how immunizations and lack of herd immunity can affect children in schools. An immunization concern in public health is the downward trend of kindergarten immunization covered for those being audited in the 2024-2025 school year. This was our kindergarten immunization audit, and there is a new stricter methodology this past year for determining the coverage rate. So that could have impacted these numbers and the decreases, as before credit was given for vaccine doses, even if they were given at the wrong age or the wrong interval, as long as they were given. And now that will not count toward the immunization audit as being vaccinated. However, regardless of the tightening of the standards, the kindergarten coverage percentages in Kentucky are below the recommended coverage rate and appear to be on a downward trajectory. However, the 7th grade and 11th grade rates were holding steady on most immunizations at recommendations for herd immunity, except for the 11th grade meningococcal coverage, which was lower than expected. In the kindergarten group, all vaccine compliance with DTaP, polio, measles, mumps, rubella, varicella, hepatitis A, and hepatitis B, these are the vaccines that we audit, were all under 90% coverage, which we strive for in public health. Most of these coverage percentages were still barely enough to maintain herd immunity because they were a little above 85%, except in community clusters of unvaccinated individuals, such as in my home state of Texas this past year. However, measles is highly contagious and therefore requires about a 92 to 95% coverage rate to maintain herd immunity. Pertussis is also highly contagious and requires a 92 to 94% coverage rate. And in Kentucky, what we've got right now, this past audit year, all vaccine together was 82%, DTaP is at 86.2%, polio is at 86.7%, MMR is at 86.9%, and varicella is at 86.2%. This is very concerning to those of us who work in school health and in public health. What I see directly dealing with school health and parents is the younger parents are particularly susceptible to doing their own research, but not necessarily evidence-based studies. They are also further away from knowing or hearing of a family member or older adult who had complications from these illnesses, making the risks seem more theoretical. I know that as a pediatric nurse, when I was starting out, I took care of patients with bacterial meningitis, epiglottitis from Hib. I even saw a child that we had to send to another facility for further care that died from varicella. And, you know, I had an algebra teacher in junior high that had complications of polio. What is happening is these younger people are not seeing this. And I think that's very evident in the fact that the 7th grade and 11th grade audits are still better. So it's getting worse the younger that we see these children. And I'm afraid this trajectory is going to continue. Right now in school health, we're seeing a lot of religious exemptions, as they are a lot easier to obtain than medical exemptions. Basically, all the patient has to do is have them signed and they sign them. The only way you can get a medical exemption is for immunocompromised or allergy to specific components of the vaccine. So that's harder to do. So they tend to use religious exemptions more. The problem is if there's not herd immunity, there's increased potential for school absences, outbreaks in the schools, and interruptions to education. This also has an economic impact due to lost school time and increased medical bills. As we saw during COVID, schools are strained when managing outbreaks in the school setting. It was very difficult. The ultimate issue here is that lack of vaccination can affect the health and well-being of students. We have a public health nurse in all 13 of our schools in our county provided by the health department, and we provide vaccine for children in the school settings to improve our immunization statistics. Without herd immunity, those students with chronic illness and those who are immunocompromised are at greatest risk. And so the herd immunity helps protect them and enable them to be able to attend school. In our county of slightly less than 50,000 citizens, in our school alone, in our school system alone, we have 7 type 1 diabetics, 1 student with rheumatoid arthritis, 1 with Hashimoto's, 2 with hemophilia, 1 with cystic fibrosis, 1 stem cell transplant, 1 liver transplant, and 2 heart transplants. In addition, we almost always have 1 or 2 students that are currently undergoing chemotherapy. We immunize children for their health, and especially for the health of these children who may not be able to be immunized or may not have effective protection due to in immunocompromised state. Thank you very much.
Well, thank you very much. I appreciate those comments. It's quite enlightening, to be quite honest about it. I'd like to bring up our next speaker, and that is Mr. Tom Walton. Mr. Walton is an executive in residence in health management and system sciences at the University of Louisville School of Public Health and Information Sciences. Mr. Walton earned a Master of Science in Social Ethics and System Science from the University of Louisville and a Master of Divinity at the Southern Baptist Theological Seminary. As a population health consultant, he has extensive experience and expertise in population health, working with several local, state, and national healthcare, as well as governmental agencies. Mr. Walton, can you share your perceptions about vaccines?
Sure. The other presenters have discussed the clinical impacts of vaccination. I've been asked to talk about to reflect on the economic impacts. To illustrate this impact, my approach will be to walk through a scenario about the economic impact on a family whose members were not vaccinated, and then discuss economic impacts at an organizational and societal level. The family scenario is a family of 4, 2 parents, a preschooler in daycare, and an elementary school student. The mother works full-time as a nursing assistant at a nursing home, earning $18.25 an hour, or $790 a week, which is the average wage for a nursing assistant in the state of Kentucky. She's enrolled in a high deductible insurance plan for the family through her employer. Dad is a rideshare driver earning $16.67 an hour for 28 hours a week, or about $506 a week. The preschool child brings home an infectious disease from daycare. The dad stays home for a week to care for the sick child. The mother and the elementary school student become ill and miss work and school the next week. Since the dad is a gig worker with no paid sick time, he loses a week's wages, $506. Nationally, a family with commercial insurance pays $3,564 in out-of-pocket medical expenses. In this case, the money spent to address this infectious disease may be spent on over-the-counter remedies, a provider visit or urgent care copay, or prescribed medications. Daycare expense will continue to be paid even though the child is not there. Conservatively, this would be $150 weekly or $30 a day, and we know that in many Kentucky counties, it's a much higher rate. These seemingly small shocks like medical bills can create financial risk, like an inability to pay for food, rent, or transportation. The organizations associated with the family are also impacted. The mother's employer, a nursing home, will have an expense impact of $1,580, $790 to pay the mother's sick time, and another $790 in replacement cost of an absent employee. The student's elementary school will also lose revenue since average daily attendance impacts funding. Generally, all employers who offer health insurance are impacted by infectious diseases. Nationally, the annual spending by on behalf of a family of 4 with employer coverage topped at $29,000 in 2024. As mentioned above, the family out-of-pocket expense was $3,564. the family contributed premium cost of $6,296, and the employer contributed $19,276. The cost of commercial insurance plans is expected to grow by 6.7% in 2025. Rising healthcare costs cascade through an employer, perhaps by limiting wage growth, investments in new capital, research and development, or workforce development. In Kentucky and most states, a major driver of cost is hospital stays. The estimated average cost of a day in a Kentucky hospital is $2,824. If an infection causes a 4-day length of stay, the cost will be approximately $11,296. A vaccination may help avoid a hospitalization or reduce the length of stay. I'll mention a few studies which discuss the economic impact of vaccinations at a societal or global level. A study in Colorado looked at the medical expenditures of people who were diagnosed with COVID-19 between April 2021 and July 2022. The authors found that during the acute phase of hospitalization, within 30 days after diagnosis, average acute medical expenses were $194 less for vaccinated children compared with unvaccinated children. For adults, the expenditures were $1,743 less for vaccinated patients. A 2015 study from the Eshelman School of Pharmacy at the University of North Carolina estimated the economic burden at approximately $9 billion in a single year from vaccine-preventable diseases related to 10 vaccines recommended for adults 19 and older. Unvaccinated adults accounted for almost 80% of this financial burden. An updated estimate put the economic burden at $27 billion in 2023, with the flu being the biggest contributor to this economic impact. Turning to a global perspective, Johns Hopkins Bloomberg School of Public Health looked at the economic benefits of vaccines in 94 low and middle income countries. The study found that while looking at costs associated with illness, such as treatment and productivity losses, the return was $16 for every dollar spent on vaccines. A cost of illness approach measures averted treatment cost, transportation cost, lost caretaker wages, and productivity losses. The global perspective is important because an infection in another country is only a plane flight away from an infection in the U.S. The National Academy of Medicine estimates that missed prevention costs 30 cents of every healthcare dollar. Now, not all missed prevention costs can be attributed to vaccines, but vaccines have a significant impact on disease prevention and mitigation. A paper on the impact of vaccines, health, economic, and social perspectives begins with a quote, "The impact of vaccination on the health of the world's people is hard to exaggerate. With the exception of safe water, no other modality has had such a major effect on the mortality reduction and population growth." A few key takeaways. In 2023, the U.S. spent $4.9 trillion on healthcare, around 18% of the gross domestic product. The Centers for Medicaid and Medicaid Services projects the 2025 healthcare spend to be $5.6 trillion. Increased vaccinations will help slow the growth rate by avoiding cost of illness costs, and ideally, money spent by employers and government agencies on vaccine preventable illnesses can be used to fund other health services such as increased primary care or other prevention programs, or non-healthcare areas such as transportation, housing, digital infrastructure, or workforce development, which will also increase the health and well-being of a population. Thank you.
Thank you very much. That is an interesting way of looking at what illness impacts us in ways that we don't even think about. Our next and final speaker is going to be Ms. Allison Adams. Ms. Adams is the President and Chief Executive Officer of the Foundation for a Healthy Kentucky. She has a Bachelor of Science degree in Sports Medicine from Marietta College and an RN degree and a Master of Public Administration from Northern Kentucky University, and has completed the Kentucky Public Health Leadership Institute from the School of Public Health at the University of Kentucky. She is the past District Director for the Buffalo Trace District Health Department and a past President of the Kentucky Health Department Association. Ms. Adams, can you please share a few thoughts with us?
Sure. And good evening, everyone. And thank you, Dr. Tuckson, for inviting us to this panel, as well as all the rest of our previous speakers. It's a pleasure to be with you all tonight. I have been asked to talk a little bit about the vaccine policy, and we've heard from Dr. Kudak in respect to, what his worries about the potential repeal of some of the mandates in Kentucky and, what his worries around Florida. And we here at the Foundation for Healthy Kentucky also share that worry. So it's my pleasure to just share with the group some of our thoughts around vaccine policy. When it comes to vaccine policy, including mandates, decisions are primarily made at the state level. And this is something that, we pride ourselves as individual states, but we also follow the recommendations from our national public health authorities like the Centers for Disease Control. Local health departments, county governments, education agencies, and employers also play a vital role in how these policies are implemented. Their role could be outreach, their education. They, in each individual institution, can have their own specifications around vaccine mandates. And so they can also make sure that vaccines are accessible in every neighborhood. You'll hear a common thread around our presentations today, which is making sure that we maintain the accessibility of vaccines to all Kentuckians. But just as important as the role of the public, citizens, our neighbors in Kentucky, influence vaccine policy, not only through their elected officials, but also through everyday engagement. And so I just want to encourage our audience, just by showing up, speaking up, being here today, sharing the information that you learn, partnering with other local organizations, these everyday activities and engagements can help roll back some of the misinformation that we're combating here today on tonight's presentation. When communities express that trust in vaccines and advocate for access, it begins to empower the policymakers to prioritize resources for outreach and distribution. And I can't stress enough the power of your voice to your policymakers and letting them know that the squeaky wheels aren't always the loudest. It's the ones who have that trust, that middle group that you've heard talk about today is really focusing on how you express your trust from your physician and from your role as a parent or a caregiver in choosing whether or not to vaccinate. And so I just encourage you to keep being involved in town halls like this, health coalitions in your local community, participate in school board meetings. Your public voice really does help shape and tone the direction of the vaccine efforts. And like I said, as you've already heard, there has and still is a consistent effort to amend Kentucky law and rescind vaccine mandates. Those mandates that we have come to rely on as public health officials to make the healthy choice the easy choice. It's really important that citizens, parents, nurses, and physicians alike let their voices be heard to their policymakers. And here at the Foundation for Healthy Kentucky, we advocate and support that vaccine mandates are the gold standard public health protection policy and law. And we're very much committed to making sure that our voices is heard in combating any threat to that mandate. However, even if the mandates are repealed, we firmly believe that we should make sure that we protect access and choice, and that should remain strong for all Kentuckians. Every Kentuckian deserves a simple, trusted way to protect themselves and their families. And like you've heard here today from our panel of experts, vaccines are good. They prevent illness. They prevent our rising costs of healthcare. And, they simply are, like Tom said, they are a public health win. And perhaps I will say that many people who are on the call today or your friends and neighbors, they've not witnessed the diseases that these vaccines protect. And so we're not really truly discerning the risk benefit from vaccines. And so I think that that's another area that as you're advocating is remembering how many deaths, disease, and disabilities that we are preventing with vaccines. So that means what we just need to continue to expand our outreach and education, public health officials, policymakers, physicians, really continue to communicate and combat the misinformation that we're all hearing louder than the truth, and really focus on reducing all the logistical barriers that make it very hard to access or to truly make that the correct or the informed decisions. And so finally, just in wrapping up and like how you can be involved, we all have a role to play in, protecting vaccine access for our all Kentuckians, but then mostly making sure that those who cannot get vaccinated, we're protecting our friends and neighbors through herd immunity. And so just really focusing on, we're all in this together, policymakers, doctors, nurses, pharmacists, and neighbors, we all have a role to play. And, the Foundation for Healthy Kentucky has done some focus groups, and we really we have come to understand that patients want to hear from their doctors. They want to hear from their providers. So carving out some time to understand why your patients or why you decide you're not getting that vaccine, and really discern with that patient. And we are finding out that if they have that 30-second, 2-minute conversation, moving them to actually get the vaccine has proven successful. And so finally, just to wrap up, we really understand that vaccines need to be available. They need to be accessible. And I'm sure Denise, my colleague Denise, will agree that if we get the, get the informed decision and it's made, we want to make sure the vaccine is accessible, and working through the Vaccines for Children program, having the vaccines ready when the commitment is made is essential. So assuring that we are reducing all barriers, misinformation, logistical, making the vaccine available when the choice is ready to be made is truly the best standard and the gold standard for moving consent to action. So Wayne, thank you. I just encourage everyone to keep watch on the policy making in Frankfort as we move into the 2026 General Assembly session.
Thank you very much, Allison. And thank you to all of our panelists. Now is the time for you who is out there listening on Facebook Live, and if you have a question, comment, or thought to share with us, please type it in and we'll get to it. Let's start off with you, Denise, because we have a question about vaccine. We can have all of our speakers can come on out of that Netherlands that you are in right now and join us so we can see your smiling faces. But Denise, the question was, can we get more vaccines into schools and get younger parents more involved in this? What are some of the approaches? And then I'm also going to get Tom to chime in on this also. But Denise, you first.
Well, I'm a big advocate for school nurses, and I love having public health in the schools. And I have definitely advocated for that over the years and kept my nurses in the schools, even when a lot of people pulled out, because I think the only way we're going to change the health of Kentuckians is to work on the health of children. And we actually do immunizations in the schools because a captive audience is your best way to get immunizations done. We have a program through the Vaccine for Children program where we have our transport planned and approved by the state, and we do all of the appropriate storage and everything for vaccine. And then the nurses send VISs home, and they allow parents to come in if they want to be there. And we do the vaccinations in the school setting. And that definitely helps our vaccine rates in Hopkins County. And it's very convenient for parents because if they work, then they don't have to take a day off if that's a problem for them to get their vaccines done in school. And actually, I'm sure the pediatricians on here can attest to this. The children tend to do better when their parents aren't there, but we do invite the parents to come if they want to, but sometimes it's easier if they don't.
Sounds good. Tom, I want you to put your ethicist hat on, or your ethical perspective into play here. What is that discussion about telling this younger person who is saying, I don't want my child being vaccinated, but yet we know the consequences thereof? What is that discussion going to be?
I think I'd like to start with something Mike said about the middle people. And I, and again, I'm a big advocate of listening to the people, the solutions in the community, the problems in the community, but to actually have some very in-depth discussion, to listen to the mental models of the people that are in the middle or the people that are vaccine hesitant, and understand, again, as Allison talked about, what really are the barriers to that. Ethicists think a lot about mental models. What's the source of power? What's the source of truth? What's the source? And to sort of understand that. And I don't think we can underestimate the impact of social media and helping people form their worldviews. So again, and maybe the intention would be is to find that cohort within the middle who is open to vaccination, and have them actually design the program that would increase the vaccination rate of the children, their children and the children of their neighbors. But really, it's this idea of listening and understanding the mental model of the people that are vaccine hesitant, and have that being the foundation for any kind of program design.
But Tom, tell me, most of these parents got vaccinated. And now they're saying, I got it, but I don't want to give it to my child. I don't understand the disconnect. Can you perhaps help us there?
Well, I think Denise talked about it when she said that people have not seen the consequences of people. Again, my own mother, who's, in her 90s, saw a child with polio, and the patterning that had to be done, for him. And so it's in her mental model that these are devastating diseases. And again, I don't think that, if I understand Denise correctly, people are not understanding the impact, and that, and then even, Mike talked about people that, that died, or, because they were not familiar with these diseases. Because right now, I think that people think like, well, some authority who might not be my authority is the one who's telling me to get this disease, and they're not making any connect to their own personal health and well-being. And then, I was asked to talk about the economic impact, so I'm going to talk about that also. Is really, I don't think people understand, that, a hospitalization is a very expensive endeavor for the person, particularly if they're the family, if they're in a high deductible plan, but also it's what's feeding into these rapid increases. And I didn't mention this, but the health insurance, the commercial health insurance is expected to go up to 6.7% next year. Medicare and Medicare is expected to have a 4.5% growth rate, and Medicaid a 3 to 4% growth rate. So again, I guess, I myself have been a budgeteer in the past and helped develop hospital budgets. So we thought a lot about the consequences of the decision we were making. I'm not sure that, parents are making that connection between the decision not to be vaccinated and the potential economic impact on their family's budget.
Thank you for
I
sharing that.
wonder if I could chime in there on this question. I talked to, and like Mike probably, I talked to a lot of parents who are very hesitant to vaccinate their kids. And I think the not knowing the diseases is one piece of this, but I think another piece is that I feel bad for these young parents. They are bombarded continuously with information, misinformation, disinformation. They don't know who to listen to. And they can ask Dr. Google things and get the answer from Dr. Google, and they can listen to our politicians and people who maybe don't have the same foundation that Mike does, or other Mark does, people who see patients. So I feel bad for them. So I think one of our roles is to help them sort out the wheat from the chaff, and to gain their trust. I went into pediatrics because I care about children, and so did every other pediatrician I know. They didn't go into it to become rich, I'll tell you that. And, and so, to think that we would knowingly advocate for something that instead of benefits children harms them, it doesn't make any sense, and it's not true. And one other thing I would say about the ethics here and about vaccine refusal, I struggle with this. If you're a 3-year-old and your parents have refused to get you vaccinated, you don't have a voice. I mean, you don't. So who is the voice of the 3-year-old who, if asked, do you want to get measles and have a 1 in 500 chance of dying or getting encephalitis? Who can answer on behalf of the child? Well, that's called society. And that's why we don't let 5-year-olds drive cars, because the government says that's too dangerous. You're going to hurt yourself or harm someone else. And so I look at the vaccine mandates as something very much along those same lines, that you may have a right, you have many rights as a parent to, but you also have responsibilities. And one of those is to protect your child. And that's why you put them in a car seat. And that's why you teach them about all these other things. And I don't see vaccination as anything different. And so that's where mandates come in. They say, we have an obligation to protect the children in our society.
That's
Gary, while you have this, I'm sorry, please go ahead. Go ahead.
No, that's a really great point, Dr. Marshall. And just to kind of piggyback on what Mr. Walton said with ethics, we regard parents as people that are there to make the right decisions for their children, right? But I think in a lot of the debate right now, what's getting lost is they should be, you got to do the right thing for the child. So, and I think that's where a lot of this comes from. So, and yeah, without the diseases out there to kind of constantly remind you, it becomes a difficult decision. I mean, the media that you get is so filtered, and depending on what you tune in or what your algorithm says that you're going to listen to today, the information you get can be very, very focused. But yeah, I think we kind of forget about that. And parents should be there to advocate for their children. And I think it's our responsibility to get the positive information out there and say, listen, we are preventing disease with these things. So, by the way, on the profit taking margin, pediatricians drive Hondas, okay?
But I think, but the point that was raised, though, I think is a very important one. And that is, we have to get the information out so people can make informed decisions, or at the very least, be comfortable for things. If we come along and say, we're going to mandate this. But let me ask you this, Gary. Anti-vax groups spread fear about RNA vaccines and how they may or may not affect our genetic material. Can you really explain what RNA is, and and is this material affecting our genetic makeup when we get these types of?
I'll answer that question first. No, it's not. It's not DNA. DNA is the instructions in every one of your cells that tells your cells how to become skin cells or brain cells or heart cells and how they should function. RNA is the way the information gets from the DNA and gets converted into a protein, which then performs a function. So the M stands for message. So the mRNA is the molecule that transmits the message. So in the case of mRNA vaccines, which, by the way, this technology had been around and had been used in humans for 20 years before the COVID pandemic. And it had been perfected in terms of making sure that it could work and that it was safe. And it's not to say it's not reactogenic. So those of you who've had your COVID shots, yeah, it takes you down for a day or two, but that's good because that's your immune system revving up to fight, COVID. So I look at mRNA vaccines as really nothing different than a protein vaccine, because in the end, that's what it is. The mRNA goes into your cells and instructs your cells to produce the protein that then creates that's the antigen, and that's what your immune system responds to. So in the case of COVID, the RNA codes for the spike protein, and the spike protein is expressed in your cells, and then your immune system recognizes it. And by the way, it's expressed there with better fidelity than it is if you tried to isolate it off of the virus and put it into a vial and use that as a vaccine. Although that one of our vaccines is like that too. After you get the shot, the RNA hangs around for a little while in your cells to produce that protein, and then it gets chewed up and spit out because RNA simply is a wimp. It literally cannot survive. You have enzymes all over in your cells that are called RNases. Their job is to chew up pieces of RNA that have done their job. There are some studies that show the persistence of RNA in certain lymph nodes that drain the site where you get the shot, but that doesn't alter your DNA. It doesn't alter your genetics.
Mark Burns, sort of along the lines we were talking about the younger patients, what is the best practice in educating older adults about getting vaccines? Because there also is a problem there.
Well, basically, with the older adults, in my experience, I've noticed they're the ones who are not, or should I say, anti-vax. They seem to be more politically aligned with whatever people are saying. I'm talking about the older adults.
Yes.
I mean, they a lot of them have been vaccinated with all the other previous mandatory vaccines, like measles, mumps, rubella, those types of things. So they understand the importance of it, but for whatever reason, and I can't explain, they want to align themselves with certain political ideologies, and following those and what's said about those types of things. Certainly nothing scientific, or at least none of the reasons that I've been given by these older individuals.
Mark, what do you consider old, by the way?
You know what? I know what I used to think, and I know what I think now, and there's a big difference.
We won't even ask the ethicists on this one. Allison, with some of the changes that are being coming down the road as far as cutting back on Medicaid funding, what changes do you anticipate that we'll see with the availability of children and even adults getting vaccines covered? Do you think that this may be a problem for us?
Yes, I think that there is a real fear in knowing what is covered. We have a lot of, again, misinformation, disinformation around like what vaccines are covered by insurance, which ones are covered with the Vaccines for Children's program, which is a federal program that Denise can pipe in on. I think when we talk about prevention, most insurances, public and commercial, are supposed to be covering this. There might be a copay, but the surprise billing that's associated with vaccines really are cost prohibitive. Sometimes vaccines are fully covered, but that's after a deductible, or it's included in a deductible. So there's a lot of surprising cost around vaccines, and I think that this just continues to exacerbate or make worse the problem of understanding what's covered and what's not covered as we're swirling in the conversation of reduced Medicare and Medicaid benefits.
Mike, you may not see it as much in the pediatric population, but it's definitely in the older population. A lot of places won't, they say, we want you to get your vaccine, but go to the pharmacist to get your vaccine. Is that a barrier to people getting their vaccines? Because now you got to go to another place, or who's picking up that cost?
Well, let's roll things back 10 years, back when vaccines were, I guess, say more available, maybe less restrictions, less opposition, less concern. The biggest barrier was just the patient's age, because the pharmacist would not vaccinate below a certain age. The other thing is that, Dr. Tuckson, who would you want giving your vaccine? Somebody you've never seen before, or, trusted nurse Lisa, who has put you on the scale since when you were 2 weeks old and you've got to know over time, right? So a lot of people want to get their vaccines in a familiar area. So I think that is a way to decrease those barriers. The biggest barrier right now is there's just a lot of confusion coming out of Washington right now. So, and I actually think that's intentional because just with the COVID vaccine, the rules around a COVID vaccine have changed 2 or 3 times in the past couple of months. So, and then we're hearing things about other things too. So, and the thing is, whenever the federal government introduces some sort of hesitancy to something, it's like, we're going to recommend this. No, we're going to do this. No, we're going to do this. And people are not going to give it or take it because payment is like, okay, it's up in the air. So, if you give a vaccine, vaccines are not inexpensive. If you give a vaccine, you're not going to get reimbursed for it. It can be pretty significant to the provider. So,
Denise, there was a question about, are disease outbreaks driven by vaccine shedding or because of unvaccinated individuals? What are you seeing is from the public health perspective?
Well, what we're seeing is the outbreaks, just like the 2 pertussis cases in infants that we have this week in our county. They are both unvaccinated individuals who one should have already had 2 DTaPs, which is the diphtheria, tetanus, acellular pertussis, and one should have already had 3, and they both had 0. So what we tend to see in vaccine preventable diseases is the unvaccinated are the ones that are being infected with these diseases at this time.
Can I add
Dr.
something to that?
Tuckson, you don't mind if I can comment just real briefly?
Please, go ahead.
And I've said on numerous occasions, I'm use COVID-19 as the prime example. There's no question in my mind, we could have totally eradicated COVID-19, okay, just like we did the SARS coronavirus 1, totally eradicated if the vast majority, and I would dare say everyone, had gotten vaccinated. The virus would not be able to replicate and have no place to go. But because we had so many people unvaccinated, the virus had a chance to not only replicate, but also mutate. And that, even today, is what continues to promulgate COVID-19. And that's most likely why I very reluctantly and unfortunately say, I don't think we're ever going to get rid of it.
Interesting. Gary, go ahead.
Wayne, to the question, I think the question asked also if outbreaks are being caused by shedding of the vaccine.
A virus in people who may have been vaccinated, or
I
just
see.
strictly the unvaccinated individual.
Okay, so that brings up a really important point, which what's the goal of vaccination? Well,
Yes.
we want to keep people healthy and keep them out of the hospital, but we don't always have as the goal to prevent infection. And that's a really important distinction for people to understand. And I think, Mark, you might agree with me here that part of the problem with COVID was the messaging around the vaccine, because when the first studies came out in 30,000 people each study, they suggested that if you get this vaccine, you won't get COVID. You won't even get the infection. And so the idea was that we had a vaccine that caused sterilizing immunity. Well, then we learned very quickly that it doesn't really prevent you from getting infected necessarily, but it does protect you from getting really sick. And then the messaging had to change. And that's when things kind of went downhill in terms of the public's understanding. But there are some diseases that we want sterilizing immunity, and there are others where we're okay with, well, the flu is an example. We don't prevent you from getting the virus necessarily, but we can pretty be sure we'll prevent you from dying of flu or for being hospitalized, or as someone said earlier, having a stroke or a heart attack related to flu.
Yes, 1.3 million people died from COVID virus here in the U.S. And I believe that was more than any other country on the face of the earth.
Yep.
Okay. And vaccination, the major point, and you're right, the marketing had to change, and it was difficult to get people to understand. No, the vaccine does not prevent you from getting COVID, but it decreases hospitalization and death. Those problems would be abated by being vaccinated for COVID.
And to your point, Mark, I think I was just reminded that you don't need a prescription if you're an adult to get a vaccine at a pharmacy. So we can still go in there and get things done.
Yeah, it's again a lot of confusion presently out of Washington D.C. I try to tell people consult with your primary care provider.
I want you to be more specific when you say Washington. I'm from Washington, D.C. It's
Oh,
just a
sorry.
certain section of Washington, please. Mike, are we outliers here in the United States in terms of the number of vaccines that we're giving kids and in that short period of time, or are we pretty consistent with everybody else?
No, this is entirely consistent with the European vaccination schedule. There's some slight differences, but the general theory of giving kids vaccines frequently over the first couple of months of life to prevent them from something that's going to kill them is pretty consistent. So, and I think most our vaccine schedule is pretty much in line with that of the World Health Organization, European Infectious Disease Society, Australia, New Zealand. I mean, we are not outliers. What we were outliers with, going back to what Dr. Burns said, was our mortality rate, and because the American life expectancy dropped 2 years during the COVID pandemic. It's not come back yet. So everybody in America is going to live 2 years less longer because of our response to COVID. So,
Gary, some people remember that there was a subset of population during the polio vaccination period who came down with polio. So somebody gets a vaccination, what are the chances that they may actually get the disease for which they're being vaccinated?
Do you mean from the vaccine?
Yes, from the vaccine.
From the vaccine.
If I remember correctly, there was a problem with as far as the preparation of that. And could you tell us about what the issues were around there?
Absolutely. So that was the Salk vaccine, and that was the one that was Salk took the live virus and inactivated it with formaldehyde or formalin and used that as a killed viral vaccine. The problem was that there were some lots of that vaccine that were insufficiently inactivated. So there were actually some live viral particles in some of those vials. And there were kids who got polio. There's a great book about this called The Cutter Incident, Cutter, by Paul Offit. Cutter was the company that was making that inactivated vaccine. So yes, that's really, in fact, that event sparked a whole new science of vaccine safety. And, looking critically at, are we fully inactivating every bit of that virus so it doesn't cause the disease? So as we stand today, the only vaccines that are even capable in any way of causing the disease are the live attenuated vaccines. So despite what, your grandmother or your parents might have told you, they got the flu shot and then they got the flu. If they got the inactivated flu shot, they did not get the flu from the flu shot. But that being said, we actually want you to get measles when you get the live attenuated measles vaccine. But the whole point is you're getting a weakened form of the measles so that you develop a robust immunity, but you don't get sick. Now you might get a little fever, and some kids actually get a rash. But this is how the live vaccines work. So they're the only ones that could possibly cause the disease. And that really only happens in people who are not immune competent. Now, you would never give the live measles vaccine to a child who has an immune system problem. Denise mentioned a few that go to our schools, right? So, but there, on very, very rare occasions, there might be a child who, unbeknownst to anyone, actually has an immune problem, gets a live vaccine, gets the disease. But remember, the disease they're getting is an attenuated or weakened form of the disease. It'd be much worse if that immunocompetent child got the natural measles. So, and that's, I think Denise was talking about kids in school who can't get the vaccine because they can't take a live viral vaccine. Well, guess what? The only way you protect them from measles is if the kids around them are vaccinated. And so that's part of our responsibility, I think.
I wonder if Mike and then perhaps Tom can talk about the benefit of doing this, but we hear every now and then about chicken pox parties. We'll bring the child who has chicken pox and expose them to a whole bunch of people. Now, like I said, that's why I want to hear Tom's position. But first, Mike, what is the difference between natural and vaccine-acquired immunity?
Let's see. From an antibody standpoint, if let's say for chicken pox, it should be the same because your body should be making antibodies against that virus, right? So the strain of the varicella virus that's in the vaccine is something called the Oka strain. That was the town in Japan where it was discovered. They discovered that, okay, people here are getting infected with chickenpox. It was a very mild strain. It's like, okay, let's tone this down a little bit more and then go ahead and put it into a vaccine. So that's kind of where that comes from. So let's see. I've read, okay, people are having measles parties now. They're trying to deliberately infect their children with measles, which to me is crazy. So varicella, we used to kind of think, I mean, if you were younger, you got it, you were exposed to it. Some people got pretty sick from it. Most people got through it just fine. So,
Yeah, but is the immunity the same if you get it because you've been exposed to something, or is it better or not as robust if you've got a vaccine that
it's probably just as good because if you're re-exposed to that virus and you don't get it, then your immunity worked, right? So, getting back to chicken pox, it's not so benign anymore because if you're dealing with somebody that's immune compromised, chicken pox is a quickly lethal disease. We've got a couple of infectious disease doctors on our program tonight that will attest to you about how devastating that can be. The other thing is we now have a bacteria called MRSA that lives on a lot of people's skin. And secondary infections of chickenpox lesions were really common, but that was in an era before MRSA really existed. Now, breaks in the skin for somebody that's got that's colonized with MRSA, that could really lead to life-threatening infection. So chickenpox is no longer a benign disease. So I'll pass on the chickenpox parties.
All right, Tom, come on, tell me the truth, man. So if someone says, my child is not been previously infected, but we have a kid in the neighborhood who is, and we're going to go over there and have my kid get infected. What's the answer to that? And don't tell me the middle ground again.
The opinions I express are my own and do not reflect those of any organization with which I am affiliated. To quote Mike, it is really just crazy. And I'm going back to earlier when we talked about, a primary responsibility of a parent is to protect your child. And I would add to that, a primary responsibility is to protect your child and reduce harm in any way possible. So to me, the idea of going to, when you have all of these unknowns about, is their child immunocompromised? Are there, you don't know how strong the disease is, that you are not really working to protect your child. So again, I really think that, the underlying theory might be great that you want to, stimulate these natural immunities. But I think what, we were talking a minute ago about, is natural exposure as good as a thing? Again, I think it's really a misinformation issue where you think that the natural exposure might do a quote unquote better job of protecting your child.
This really bugs me when people talk about getting natural measles is more natural.
Yes.
Because there's really nothing unnatural about the vaccine. It is the measles virus. It is just a weaker version of it. And it gives you a very, very small case of measles that you don't even recognize. So the idea that it's not natural is wrong. And, the cost of the measles party is a 1 in 500 chance that your child will die. And the cost of getting the vaccination is a virtually 100% chance they're not going to get measles, the real disease, and a 1 in a million chance that the vaccine will cause a really serious harm in your child. And I mean less than 1 in a million, honestly.
All right, I want the 30-second summation from each of you. What is the biggest point that we should think about when talking about vaccines. We're going to start off, we're going to go in reverse order. So Allison, what is your 30-second take-home point? And then we're going to go Tom, Denise, Mark, Mike, and end up with Gary because he talks the most.
My 30-second is 2 points. We know that we want to hear information from our primary care provider, our physician. So engage in those conversations. They're they're going to tell you vaccines are safe, vaccines are good for all ages. And be able to discern with you. And then second is making sure that you get involved in in the policy making process, the advocacy piece, the sharing of information. It really does take take all of us to share information and be able to direct people away from the algorithms that they might be spiraling down into.
Thank you very much. Tom.
Trust is critical. And I think we need to understand people's ethical and mental models for this lack of trust that makes them susceptible to misinformation. And my second point, because I was asked about to talk about the economics, is disease is expensive. It's expensive to families, it's expensive to organizations, and it's expensive to society.
Thank you very much, sir. Denise.
Immunizations are one of the most important public health initiatives in the history of the world. They're readily available in the United States, so we are so fortunate. They're low risk and high reward. We need to work really hard in teams like this to combat the misinformation that's being spread.
Thank you very much. Mark.
My main takeaway is that immunization is the key to primary health care. It's an indisputable human right, okay? It's one of the best health investments money can buy. Vaccines are very critical for the prevention and control of infectious diseases and infectious disease outbreaks. They underpin global health, and they are a vital tool in the battle against microbes.
Thank you very much, sir. Mike.
Let's not forget about the diseases that we're trying to prevent. So if you have ever had the not so nice privileges of seeing or witnessing a child with pertussis having a coughing episode, and you watch them wheeze and gasp for air and turn blue, you would say, boy, that vaccine is a really small price to prevent this. So let's talk more about the vaccine. Let's talk more about the diseases that the vaccines prevent. That'll allow people to make an informed choice because we're not talking about it right now.
Gary, please.
Don't listen to me. Don't listen to Wayne. Don't listen to anyone else on this panel. We're all experts. We're all in the field. Sit down and talk to your pediatrician if you're a parent, the person who's been by your side as your child has grown up and has been interested only in their welfare. And if you're an adult, sit down and talk to your PCP and ask them, should I get the flu shot? Should I get the COVID shot? Should my kid get the measles shot? That's my message.
Well, thank you very much. Thank you to all of our panelists, and thank you to those of you who have been participating with us on this program. I want to thank the Foundation for a Healthy Kentucky, the Greater Louisville Medical Society, the Greater Louisville Medical Society Foundation, the Kentucky Nurses Association, and the Lexington Medical Society and Northern Kentucky Medical Society. This program will be available for streaming, and you can go to your sites and you can pull it up, and I encourage you to do so. You have heard from your healthcare professionals. These are people who live in your communities, in your state, right here with you. As was said earlier, we are the ones who have a vested interest in your doing well. We earn your trust, we want to keep your trust, and we want you to be happy and healthy for as long as possible. Please, I'll reiterate what Dr. Marshall said. Please talk to your healthcare provider, get all the information that you can get, and make informed decisions. You may not agree with us, but please make your decision based on good data, good information, not on hearsay, not on the proclamations, well, I heard my brother, somebody down the road had a problem with something. It doesn't work like that. In healthcare, we have a track record of what goes on, and by all means, please try to participate.